endoscopic radial artery harvesting combining a reusable retractor with a nanoscale-controlled radiofrequency vessel sealing system, early histological analysis, and late clinical outcomes.
Oh, thank you. So, despite we know that the endoscopic vessel harvesting approach should be considered the standard of care, there's always some concerns that has been raised in the past few years about potential damage occurring during the minimal invasive approach. But we now have novel technologies that are available for less invasive harvesting techniques that may actually improve the quality and outcomes even with this approach. So we investigated in a group of patients undergoing CABG surgery with the use of the radial artery, as you can read, in 36 patients, in which we utilize an endoscopic approach for radial artery harvesting. We analyze the samples from an extra length of the radial artery conduit with a primary endpoint being the histological analysis and secondary endpoint being the clinical outcomes, especially cardiac-related events. In terms of histological analysis, following fixation with formalin and embedding in paraffin, we perform H&E acid-orsine mastotrichrome staining, and we then graded the damage, potential damage occurring to the wall of the radial artery by a semi-quantitative scale with points going from 0 to 4. The approach utilized is a non-sealed, no CO2 technique that combines a reusable retractor, as you can see from Stort, and combining with a vessel sealing system like the N-Seal device that has recently been acquired by Ethicon, that uses a bipolar radiofrequency energy and a nanoscale-controlled. In terms of intraoperative data, the endoscopic approach could be completed in all patients. As you can see, mean harvest time was roughly around 30 minutes, no bleeding from side branches, no necessity to add clips, and there was no need to convert to the open approach, and no evidence of macroscopic damage. Well, obviously, as I mentioned before, we quantified histologically different damage. As you can see on a semi-quantitative scale, we could really detect negligible damage occurring to the conduits, and these are just some pictures outlining the good quality of the radial artery following this endoscopic harvesting technique. In terms of clinical outcomes, as you can see, we had excellent outcomes, both in terms of in terms of ischemic complications, paresthesias, wound complication, or bleeding complications. And then we obviously wanted to correlate with the clinical follow-up, nearly 5 years. As you can see, no neurological sequelae at the level of the limb harvest site, with very low cardiac-related mortality, and a patent area graft in the patient who had a cardiac-related mortality. The angiography was performed only in 5 out of 36 patients, and in none of them the array was occluded. So in conclusions, the combination of the reusable retractor and a sealed device is associated with limited damage at histological analysis. The use of this approach without CO2 insufflation is not associated with array graft failure and midterms, and obviously functional evaluation and further analysis are warranted in the near future. Thank you.
Thank you very much. So I propose that we have one question for each presenter. So the floor is open for discussion. So let me ask all the presenters the one question: what about the side branches? How did it look there? Because you make a cut in the vessel, and you do histology, and that's probably not representative for the whole vessel. So.
If I can very quickly comment on that. Your point is right, but I guess that all of us, when we are doing histological analysis, we, as pointed out also by the previous authors, we take a small sample at the proximal part. Usually you have more side branches, tinier set branches in the proximal side. Usually you have less set branches, bigger set branches in the distal part. And obviously, it would be optimal to analyze the whole length, but in real life, what you end up doing is usually analyzing the first bit. I don't know if the other co-authors share similar ideas.
Well, I know from our experience, well, at least the point of the study that we presented didn't specifically look at histology, but I can tell you from the literature anyway, at least from one paper, that when they did look at sort of samples of artery that either wasn't used or sort of ultimately discarded, with side branch, they found that the endoscopic technique found more damage in side branches, but then didn't really pan out in terms of major intraluminal damage between open and endoscopic. So whether that does ultimately make a difference is up for debate. I know in the same cohort of that paper, the Burris paper from 2008, when they did compare patencies on open versus endoscopic, they didn't see an ultimate difference between the two groups. So presuming then that the endoscopic group does have some more damage, minor damage in the side branch areas and in the ostia of those side branches, it didn't seem to pan out relative to the patency in the actual clinical cohorts. Histological people here can comment further on that.
I think that another point actually is that, and sometimes the endoscopic technique is not so well defined when you read the many papers in literature, and I think that just to stress that point, basically 3 of us were presenting a non-CO2 approach, while one of the colleagues were presenting a sealed system, which actually has been sometimes associated with potential damage or kind of branch avulsion, as you were mentioning, the problem with the side branches, when using a CO2 based insufflation system. But I found very interesting and reassuring that I guess if you improve the quality of your technique, it looked like that also from the functional analysis, you had very good results as well. So I find that it's always important to...
Yep. Our system uses an insulated jaw, and the heat is not dispersed that much beyond the silicon of the jaw itself. So I think that the damage to the radial artery is not that much. But as my colleague said, we only can use a small sample of the radial artery because the rest you use, of course, for your bypasses. So you're limited to the amount of tissue you get.
But still, I think it's mandatory to include, if you could do histology, to include one of the side branches, because then you have a sort of bench, then you know what you're doing. Yeah. So, and that's omitted in the studies. I think that should be done.
What we additionally did is we did optical coherence tomography in a couple of these radial arteries, so you can really look for the whole length of the graft, and there you can look at the side branches, and we didn't see any damages compared to the open technique, so it doesn't seem to be a problem.
Very encouraging. Thank you very much, speakers, and we go to the next speaker. Which is 3D endoscopic harvesting of the left internal thoracic artery using the harmonic scalpel by Takahiro